Hi everyone, I'm Dr. Rajsheker Kollipara. I'm an anesthesiologist from United States. I've been certified by American Board of Anesthesiologists. I'm an American Heart Association instructor for teaching and training basic life support and advanced cardiac life support. Today, I'm going to talk about a small topic, useful one for majority of the doctors and also for anesthesiologists. This is, when do you request cardiology consult for a patient having non-cardiac surgery? As an anesthesiologist, we have to do this every day, almost every day, when we are trying to evaluate a patient for general, regular non-cardiac surgeries. And believe me, this topic will be useful for all the doctors who have to refer their patients for surgical consults, so that way they will have an idea when to request a cardiology consult for their own patient going for surgery. Of course, these are all from the guidelines based on American cardiology of American cardiac okay. These are what we're going to discuss are from the American College of Cardiology. Okay. All right. Okay. Now, when you have a patient who comes to you for a non-cardiac surgery and you're not sure whether that patient is fit to proceed with surgery, and with either because of his general medical problems, or when you're not sure about his cardiac condition and you're in doubt whether to refer to your cardiologist or not, or get his opinion, you have to, first of all, there are some basic steps as per the guidelines only. These are all not my own steps, or it's not based on my own thinking. These are all based on American Cardiology Society's guidelines, which as an anesthesiologist we always try to follow those guidelines and refer the patient when needed. We don't try to send all the patients to the cardiologist unnecessarily. Of course, having said that, I want you to follow your local protocol. You don't have to follow these guidelines, it's up to you, but these are the guidelines set by American Cardiology Societies. And if you want to follow your local protocol and refer all your patients to cardiologists, it's up to you. But based on, this is how we practice. When and if you want to refer your patient to a cardiologist, first of all, you're trying to decide whether to refer or not. Then first you should know how to interpret the basic ECG. The reason, because if, let us say, if you're having a patient in front of you and you're examining, and patient gets you his EKG, which shows this rhythm, and if you are proficient in interpreting the ECG, and the ECG in this case, it's I can tell from my experience that it is an atrial fibrillation, and this is one condition. Of course, when you have an EKG of this sort in front of you, and you do not have any previous EKG to compare from the patient, this is only EKG that patient is brought to you, then you call that as a new onset atrial fibrillation. A new onset atrial fibrillation because the patient doesn't have a previous EKG or previous history, so this is the first time you're seeing this ECG of your patient, and you have diagnosed atrial fibrillation. And new onset atrial fibrillation is one condition where an elective surgery should be cancelled. Okay. Now, as I said, you should be proficient in interpreting basic ECG. because you never know when you come across a patient who has this kind of changes in his ECG and who is planning to have an elective surgery. If you can interpret this EKG and see some of the acute changes that have been going on in this ECG, and then decide that this patient should be seeing a cardiologist before his non-cardiac elective surgery, that means you have done some good for the patient, because this patient with this ECG changes should not be proceeding with an elective cardiac surgery. Unless it's an emergency, then that's a different story, but still, if you have time, you should be consulting a cardiologist when you come across these kind of ECG rhythms. That is the reasons. 2 cases I've shown. One is an elective surgery should not be done in a patient with a new onset atrial fibrillation and a patient who has this kind of changes on his ECG. Now, before consulting a cardiologist for non-cardiac surgeries is the topic we are discussing. As I said, there is no need to consult a cardiologist for all surgical cases. At least, as I said, this is what we follow, but if your local protocol calls for consulting the cardiologist, please, by all means, you can do that, but these were all based on the guidelines provided by American Society of Anesthesiologists and American College of Cardiology. Follow these simple steps and decide to consult a cardiologist. Step 1. First of all, know what active cardiac conditions are. What are the active cardiac conditions? The 4 you should be memorizing that. Unstable coronary syndrome or unstable angina, or recent MI, decompensated heart failure, severe arrhythmia, new onset atrial fibrillation falls into that category, and valvular disease. 1 or more active cardiac conditions are present. If 1 or more of these present, delay or cancel surgery unless it's an emergency, and patient should undergo evaluation and treatment before the elective non-cardiac surgery. So did you get it? The first step is, first of all, you have to know the active cardiac conditions, and these are the 4 active cardiac conditions. And if your patient has 1 or more of these active cardiac conditions prior to his elective surgery, then you should either cancel or delay surgery. Only if it's an emergency surgery, you have to proceed. There is no other options. So step 1 is evaluate your patient and see if he has any active cardiac conditions. Now the second step is decide if the surgery is elective or emergent. Of course, it's common sense. If it's an emergency surgery, it's a ruptured aneurysm or a ruptured appendix, you have to proceed to the OR or the operating room, and you can't delay the case waiting for your cardiologist. The next step is, having decided that the surgery is elective, if the surgery is elective, now there are certain surgeries we, as per the American Society of Anesthesiologists classification, there are certain surgeries are low risk, certain are intermediate risk, certain surgeries fall into high risk. So you have to know, of course, common sense dictates that if a patient is coming for an excision of a small mole in his body parts, then it obviously becomes a very low risk surgery, a skin tag or skin mole, etc., etc. And obviously if the patient is going to have a major abdominal surgery like aneurysm repair, it becomes a high risk surgery. So in between there are different surgeries which fall into so-called intermediate risk surgeries. So the next step is you have to determine whether the risk of surgery is low risk, intermediate risk, or high risk. For example, there are certain surgeries, as I said, one example is a skin tag, but common low-risk surgeries, or to name it, arthroscopy of the knee joint or arthroscopy of any joint will fall into low risk. Breast biopsies fall into low risk. DNCs fall into low risk. Cataract surgeries fall into low risk, etc. Now, all the peripheral lesions, lipomas, they all fall into low-risk surgery. Most of the urological procedures fall into low-risk surgeries, like cystoscopies, etc. What are the intermediate risk surgeries? Anytime patient's abdomen is open, so it's a laparotomy, that becomes an intermediate risk surgery. Maybe it's a gallbladder, maybe it's a hysterectomy. So that's called, we call it as an intermediate risk surgery. When is the high risk surgery? The high risk surgeries are revision hip joint replacements, where you're expecting major blood loss, or any thoracic surgeries, where aneurysms, so on, so forth. So you have to determine if the surgery is low, intermediate, or high. Having determined that, now you also have to determine the functional capacity of the patient. Functional capacity, which can be evaluated and categorized as good, poor, or unknown. Functional capacity is very useful thing to know from your patient. For example, if your patient says he can climb 2 flights of stairs with a bag of groceries in hands and without getting short of breath, then that means his functional capacity is good. So all you have to do is ask your patient if he can climb 2 flights of stairs without getting short of breath. That is a simple way to evaluate a patient's functional capacity. Of course, if the patient says that he's an avid singles tennis player and he doesn't have any problems playing, then obviously his functional capacity is excellent. So also, if the patient says he's a good swimmer, he swims every day, that means his functional capacity must be good. Sometimes the patient says that he can't climb 2 flights of stairs without getting short of breath. That means, that's obvious, is the patient's functional capacity is poor. Okay, so similarly, if the patient says that she cannot exercise and she cannot climb the stairs, or she doesn't give you a proper answer for your functional capacity question, then you label that person as having functional capacity unknown for that particular patient. So when you're interviewing your patient, you should be in a position to evaluate the functional capacity of the patient by asking few simple questions. That way you can categorize your patients, whether they're having a good functional capacity, poor, or if you don't know their functional capacity. So now in this step, you are trying to find out the type of surgery, the risk of surgery. Based on the type of surgery, you will know what risk of surgery is there, whether it's a low risk or high risk or intermediate. And also you're trying to evaluate the functional capacity, whether it's good, poor, or unknown. Why these are important? Because for low risk and intermediate risk surgeries, with good functional capacity, you can proceed to surgery or to the operating room without having, a cardiologist's opinion, or without prior cardiology consult is not required for low risk and intermediate risk surgeries with good functional capacity. And as we talked about some of the low-risk surgeries, excision of lipoma or breast biopsy, some urological procedures, knee scopes fall into that category. And intermediate risk surgery is a simple gallbladder or hysterectomy, etc. and etc. You can proceed as long as you know the patient's functional capacity. Now that's the reason you have to know what's the type of surgery, the risk of surgery, and the functional capacity of the patient. You have to put these things together. Now, next step is, for low-risk surgeries and intermediate risk surgeries, if the functional capacity is good, you take the patient to operating room. Now, intermediate risk surgeries and high risk surgeries with poor or unknown functional capacity. Now, before we talked about intermediate risk surgery and low risk surgery with good functional capacity, you can safely take the patient to the operating room without getting a cardiologist consult. Now, here we are talking about intermediate and high risk surgery, but functional capacity either unknown or poor. Then the next thing is you have to identify certain clinical risk factors which are called as Lee's index, and these are the risk factors: 1, 2, 3, 4, 5 risk factors, clinical risk factors. History of ischemic heart disease is one, history of compensated heart failure is another one, history of CVA, diabetes requiring insulin, and renal insufficiency. These are 5 risk factors. So why are they important? Why are they important? Because now your patient is planning to have a surgery, which may be an elective surgery. Of course, emergency surgery has to go to OR. If the patient is going to have an elective surgery, but that surgery is intermediate and high risk, and we discussed what are the intermediate surgeries and high risk surgeries, and that patient functional capacity is not known to you, then these 5 clinical risk factors will help you solve the problem or make you decide whether to send the patient to have a cardiology clearance. Now, as we said, you have to know the clinical risk factors. Why? Because if the patient is going for intermediate or high risk surgery and you do not know the patient's functional capacity. Now, you having learned those clinical risk factors discussed previously, if there are no clinical risk factors, you can proceed with surgery. Now, let us say less than 3 risk factors. There are 5 clinical risk factors we talked about. If there are less than 3 risk factors, you can proceed to OR with good heart rate control, which means if the patient is on beta blockers and the patient's heart rate is within limits, it's not more than 100, 110, then you can take them to surgery with the appropriate medications to control their heart rates. Okay. If, however, there are more than 3 clinical risk factors are present and surgery is intermediate risk surgery, then you proceed with good heart control. Mind you, this is more than 3 risk factors, but it's only intermediate risk factor and intermediate risk surgery and not high risk surgery. For intermediate and high risk surgery with unknown functional capacity, the idea is you should have either no clinical risk factors or less than 3. But when it comes to intermediate risk surgery and the risk factors are more than 3, then you can proceed with good heart rate control only. Okay, that means make sure that the patient's heart rate is well controlled. If he has to be given any beta blockers, you proceed by giving beta blockers and make sure his heart rate is well under control before proceeding to surgery with more than 3 risk factors for intermediate risk surgery. If more than 3 risk factors for high risk surgery, consult cardiologist for possible opinion and further invasive testing. Make sure that the risk factors, that's why the risk factors are very important in evaluating the patient and deciding whether to refer to the cardiologist. Again, to recapitulate, if the surgery is intermediate and high risk surgery and you do not know the functional capacity, you are supposed to know the clinical risk factors, and if your patient doesn't have any clinical risk factors, you can safely proceed with surgery. If there are less than 3 risk factors are there, you can proceed to OR with good heart rate control. Even if you have more than risk factors, but only for intermediate risk surgery, not for high risk surgery, you can still proceed with good heart rate control. This is the main thing. If more than 3 risk factors, for high risk surgery, you should be consulting cardiologist for possible non-invasive testing and getting the cardiologist's expert opinion. As we discussed, You may follow local protocols, but the steps discussed are based on American cardiology guidelines. And to again sum up, you have to, when you're deciding to see whether your patient requires any cardiologist's opinion prior to the non-cardiac surgeries, you have to be able to, you should be able to interpret basic ECG to rule out any new onset atrial fibrillations, in which case you're not supposed to be taking the patient to surgery. And similarly, if the patient has an acute ECG changes with ST changes indicative of any ischemia, that's the time you should not be proceeding to surgery. And again, you have to follow the steps we discussed, whether the patient's surgery is low risk, high risk, or intermediate risk, whether the patient has a good functional capacity, poor functional capacity, or unknown functional capacity. And based on those steps, you also should be knowing what are the clinical risk factors, what are the active cardiac conditions. You have to know all those things and put these things together in a stepwise fashion, and then decide whether your patient needs to be sent to a cardiologist for his or her elective non-cardiac surgery. And there is no reason why you should be sending all low-risk surgeries to get a prior cardiac consultation and wasting patients' resources. But again, as I want to emphasize that if your local protocols calls for cardiology consult routinely, please go ahead and follow your protocols. But this is how we practice and we triage our elective surgery patients based on the guidelines. Thank you very much.